And now my topic is medical management of thyroid-related orbitopathy. So in the medical management, first I would start with the Rundle's curve, famous Rundle's curve, where we have two phases. Initially, we have the dynamic phase followed by a static phase. So here the severity is plotted against the time. So initial dynamic phase where there is acute inflammation and we have acute signs and symptoms. And later we have a static phase where there is no inflammation, only chronic sequelae. So the management depends on both the activity and the severity of the disease. So I should thank Elvadini madam to covering most of my activity score and as well as the severity score. So the widely followed clinical activity score by UGOGO, where initially the two pain substance or those subjective readings, each point carries 1-1. As madam said, anything more than out of this initial 7 scores, anything more than 3 is considered active. And on the follow-up score, we have another 3 added on. So out of this total 10, if there is anything more than 4 is considered active. So now having graded about this activity, we'll go to severity. This madam has also covered. Thank you so much, ma'am. So as per, we have mild severity and there is no only moderate. We have moderate to severe category and then site threatening. So in mild, this is, you can see that lid retractation mild and other soft tissue involvement is also mild. Let me skip the slide as most of this thing is covered by madam. And we have the next is moderate to severe and then the site threatening. Site threatening where there is an immediate threat to vision due to dysthyroid optic neuropathy or corneal breakdown. So now treatment part. So as we start the treatment, where are the indications of medical management? So where there is an active disease, we should reduce the activity as well as the duration of activity we aim to reduce. And in those patients with mild severity, they might have impaired quality of life. So there also we need a medical management to add on. So moderate severe cases and site threatening. So in all these patients, those who have moderate to severe soft tissue signs and symptomatic exophthalmos and diplopia in functional gaze and corneal exposure and compressive optic neuropathy, we aim at treating with systemic immunosuppressant, either low dose or full doses followed. Now we will take up mild thyroid eye disease. So as madam has beautifully said about the relationship of smoking and thyroid eye disease, even those people with just the Graves disease per se, they might have progression to Graves orbitopathy in those smokers patients. So we should advise them to quit smoking. And also supportive measures like head elevation during sleeping, and at night you can tape the lid to prevent the corneal exposure. And as per the thyroid status, hyperthyroidism, as madam has said, both hyper as well as hypo patients also have the thyroid eye disease. So we should aim at reducing the hyper, bringing it to euthyroid state. So this fluctuation between hyper going to hypothyroid is very, very, increase the risk of the relapses. Okay. So, and the upcoming studies have proved that the hypercholesterolemia. So this statins adding on to the immunosuppressants which we use gives a better outcome rather than those patients of IV immunosuppressants or whatever the immunosuppressants being treated. So those who have high LDL cholesterol have been shown to have poor prognosis. Okay. So as per this mild patients, we will use lubricants. Morning you give eye drops and at night you give gels and ointments at night. Some patients might need topical anti-inflammatories, either steroids, NSAIDs, or cyclosporine can also be tried. And there's another studies which have come up. We use selenium, which is 100 micrograms BD for 6 months. This has also increased the response rate in those people being treated with management. And if those mild thyroid eye disease, few patients may have their quality life affected and they would need low dose immunomodulation therapy. If there is inactive for more than 6 months, as in this patient, we can use Botox, fillers, or eyelid surgery for lid retraction. So having completed the mild thyroiditis, we will go on the, this is the UGOGO guidelines for mild Graves orbitopathy. So now we will go to moderate to severe thyroid eye disease. So in the activity stage, the general measures are as same as the mild disease which we have talked about. Let me not repeat those. Okay. So now the sheet anchor of treatment is immune suppressants, where we have oral steroids, IV methylprednisolone and immunomodulators, of which many of the various studies have proven that giving oral steroids 1 milligram per kg body weight tapered over 6 months has 30% of them have responses, whereas 70% of them go for a relapse. Right? In those people with IV methylprednisolone given, 70% they give a good response, and whereas 30% go for relax. And few other studies, various studies, when the immunomodulators are added to the IV methylprednisolone, we have 80% of the people going in for a better improvement rather than 20% alone goes for a recurrence rate. So what we talk about this improvement or better outcome in the sense is that in the clinical activity score, even a 1 point reduction in the score is also considered as a better outcome. Apart from this clinical activity score, if the exophthalmos is reduced by 2 millimeter or the eyelid retraction is reduced, improved by more than 2 millimeter, or the extraocular movements is increased by 8 degrees in any of the directions, or the binocular field of vision, it is improved. Degree is not much involved in that. Okay, so out of these are all the better outcomes or good response for any medication. Okay, so apart from these immune suppressants, we do have immunobiological radiotherapy and intraorbital steroids in our armamentarium. So now coming to the IV methylprednisolone, which is the IV methylprednisolone is a commonly used, which has better outcome than the oral steroids. UGGO recommends the pulse intravenous methylprednisolone starting with 500 milligram or 750 milligram once a week. It's a weekly regime for the 6 pulse doses, followed by 250 milligram, and those who have taken 750 milligram drop to 500 milligram once a week for the next 6 pulses. Okay, totally the cumulative dose goes to 4.5 to 7.5 grams. At any point of time, this cumulative dose should not exceed 8 grams for the side effects. Okay, so as we all know, this methylprednisolone causes apoptosis of the activated T cells. That is what its action. Right? So for the repopulation of the T cells, it takes almost 3 weeks. So instead of exhausting the IV methylprednisolone or the steroids within a short period of time, we can still use low dose steroids for a prolonged period of time to combat the relapses happening. So in such cases, we have come up with this low dose intravenous methylprednisolone pulse therapy. Okay, where the initial loading dose is 500 milligram per day for 3 days, first pulse, followed by 500 milligram per day every 3 weeks. Okay, 3 weekly doses for the next 5 doses. This is what is the low dose IV methylprednisolone. The cumulative dose could be accumulating to 4 grams, right? So in this dosage regime, by 3rd pulse or the 4th pulse, we assess, as I said, the earlier outcome measures, whether they are responding to the treatment or not. So if we have a extremely good response or good response, we can continue with the rest of the pulses and stop when they go for the inactivity. But if we have a moderate response, then it is wise to add on with the immunomodulators. Why? This immunomodulators commonly should be add on with pulse 4 therapy rather than adding it out at the end after completing. It's because the immunomodulators, as we all know, it is slow in acting and it peaks after somewhere around 6 weeks to 8 weeks. So in that case, as we start with the pulse 4 therapy along with immunomodulators, by exhausting the 6th pulse, by then the immunomodulator will go for its peak activity and hence the relapses would be prevented. Okay. So now coming to the immunomodulators, we have mycophenolate mofetil, azathioprine, and cyclosporine. So, okay. So when coming to these in detail, so mycophenolate mofetil, it acts against T cells as well as B cells. It causes the apoptosis of the activated T cells and it has the recruitment of immune cells and inhibits the fibroblast proliferation and function. It is given in 1 gram daily for 6 months. So studies have proved that it has a superior overall response. So 91% of them had responded rather than 68% in the steroid group. And 94% has shown inactivation, which is observed. In the immunomodulators, some they do use cyclosporine, which also causes reduced T cell proliferation and interleukin 2 secretion. So it usually has a better outcome when combined with the oral steroids. So either in the study, either they either go for a cyclosporine alone or oral steroids, out of which it has been shown that more than 50% fail to respond. So though of these failed to responded people, still they responded to combined therapy. So always cyclosporine is used along with the combination of steroids. Now we have another immunomodulator, azathioprine, which also like mycophenolate mofetil activates on the activated T cells. When this also has been to combine with the steroids, and it has a beneficial effect as per the studies. Right, this is the UGOGO guidelines for moderate to severe active Graves' orbitopathy. So here in UGOGO, they have added with the 500 milligrams of methylprednisolone 6 weeks. Along with it, they have added mycophenolate mofetil. Then for the 6 weeks, then they assessed if the response is good, then they have coming down to 250 milligrams of methylprednisolone, and mycophenolate, it's continued for 18 weeks. If the response is good, stop the therapy, or if it is no response, they go in for a second line of treatment. So also they have a high dose 750 milligram of methylprednisolone 6 weeks, followed by, if there is response or partial response, then it goes to 500. Only this is methylprednisolone only treatment. So if it is no response, that also goes for a second line of treatment. So now let us look at what are the second line of treatment available. So as per the UGOGO, the second line of treatments are second dose of intravenous methylprednisolone, which is 7.5 gram. It's a cumulative dose. Or you can go in for a oral prednisolone, or the prednisolone combination with cyclosporine or azathioprine, or orbital radiotherapy, or you can have this teprotumumab, rituximab, or tocilizumab. Now we'll go to radiotherapy in a bit. Radiotherapy, the total dosage is 20 gray or 2000 centigrade, which is the total cumulative dose, which is spread along 10 to 20 doses. It's a weekly dose. So for some centers, they do use radiotherapy, but because of its side effects, the already patients having dry eye in thyroid orbitopathy, it worsens them. So as we all know, why this dry eye disease happening in the thyroid, it is not only orbitopathy, even people with Graves' disease per se can have dry eye. It is because various factors, because you have an increased palpebral fissure, and you have lid retraction, and you have lag of thymus, and you have inflammation of the lacrimal gland, where you have reduced tear secretion, and you have altered osmolality of the tear film. All these factors causes dry eye. So this is aggravated by the radiotherapy also. And also it produces not much of the extraocular motility betterment has been documented in any of the studies. And also it causes a fixed diplopia, and there are tight muscles, which is very not good to proceed with the surgical intervention later. Right. So, and all this, most of the people of this thyroid eye disease are in the population of either diabetes or hypertension. And those people, it is better to avoid radiotherapy because of the progression of the retinopathy in these people. And also, it is not advised in people less than 35 years because of the carcinogenic risk. Okay. So now, after this radiotherapy, we have this immunobiologicals. So these immunobiologicals are the drugs which, when all the things are exhausted, when you don't have any other modalities of immunosuppressions available, then they come in vogue. We have rituximab, teprotumumab, tocilizumab, and rest of the immunobiologicals are used. Now, little bit of details of this. When all it is exhausted, you have rituximab. So it is given 500 milligram of infusion 2 weeks apart. After 6 weeks, you assess. If there is not much response, still symptomatic, then go for a second pulse. That is 500 milligram infusion 2 weeks apart. So all these studies have given a better outcome of the rituximab. So one of the studies shows it is 90% of them, they have a disease inactivation at 12 weeks, and there is nil reactivation after 76 weeks. The another immunobiological is teprotumumab, which Madam has also mentioned. It is the higher drug, which is it is the first drug of US FDA approved, and it is available there, but not in our India. So it's given as an IV infusion every 3 weeks, and it inhibits insulin-like growth factor 1 receptor. So studies have given the report as 62% of them achieves the clinical activity score of 0 to 1. And it is the only drug which causes reduction of proptosis, which as similar as a comparable surgical decompression, more than 2.9 to 3.3 millimeter at 24 weeks assessment. So other immunobiological is tocilizumab. When the steroid therapy is failed, this can be used. And this studies have given, it is 86% of them have achieving clinical activity score less than 3 at 16 weeks duration, and 92% have showed improvement. So after this are the other immunobiological, etanercept, infliximab, which acts against the anti-tumor necrosis factor drug, and adalimumab, which acts on the TGF beta. So out of this, we do have recent advances. If any of the things, steroids or exhausted the intravenous methylprednisolone, then what? Still symptomatic. So then there is a chance of giving 40 milligram of triamcinolone acetate, which is given 4 weekly injection in the infralateral quadrant. So this improves the diplopia and decreases the extramuscular muscle size. So, but only thing we should be cautious in those people with steroid responders. It's because we just give the steroids at the bolus inside the orbit. So there is no control. So for those patients, if you choose to give intraorbital steroids, just give them a course of topical steroids. After 3 weeks, you try to assess. If there is no intraocular pressure increase, then you can go in for the intraorbital dosage. And also recent studies have shown 20 milligram of triamcinolone acetate, which is given in the subconjunctival upper lid injection, improves the eyelid retraction as well. So we do have initial medical management in sight-threatening dysthyroid optic neuropathy also. So where we use a high-dose intravenous methylprednisolone, the loading dose could be 500 to 1000 milligram per day for 3 days. That is the first pulse, followed by 500 to 1000 milligram per day in a weekly interval. So by second pulse, that is in 2 weeks, if there is no improvement or there are occurring of recent choroidal folds or there is luxation, then you go in for an immediate surgical decompression. So this is the UGOGO guidelines for sight-threatening Graves' orbitopathy. So in a nutshell, this is the active TED management, mild, moderate to severe, and sight-threatening. When they are going for all these measures, they are inactive for more than 6 months, then you can go in for the surgical treatment. Where the surgical treatment, it is initially, first is decompression, followed by extraocular muscle surgery, then followed by ptosis or the eyelid surgery. Okay, so that's my talk on. Thank you so much for this opportunity. Thank you all for listening.